I want to welcome everybody to our 2022-23 Clinical Grand Round Series. Excuse me, Dr. Podolsky has put together an exciting and accomplished group of presenters discussing a wide array of topics pertinent to what we do every day. And I invite each of you to review the entire schedule on our website at rootcenter.org. To start off our second year with a bang, I'd like to introduce Jeffrey Kwame. Many of you know Jeff and or are familiar with his work. However, what you may not know is that Jeff worked for this agency 10 plus years ago as a substance abuse counselor. He left this agency in 2009 to become the Associate Director of the Connecticut Certification Board, and 3+ years later became the Executive Director, a role he continues to hold today. As most of you are aware, Jeff is an expert, both nationally and internationally, in the field of opioid use disorders and continues to hold prominent positions on several boards related to the treatment of substance abuse disorders and the patients we serve. We are so excited to have Jeff present to us today. And on that note, I'm going to turn it over to Jeff.
Thanks, Darcy. Can everyone hear me okay?
Yes.
Okay, great. I'd rather go without the headphones and mic if I can. Welcome, and I'm incredibly appreciative of Darcy and Dr. Podolsky and Steve and everybody for letting me start this series off. I'm looking forward to being a participant in many as much as I am for starting off the season today. So we've got quite a bit to go through. We will have time at the end for questions. So I'll try to get them all in at the end rather than in the middle, unless something comes up that you really don't want to miss, then please raise your hand and we'll see what we can get to you. So as you said, my name is Jeff Kwame. Many of you know me. I saw Ray, I saw Sarah, I saw Dave Stein. I see some names that I recognize, people that have been around for a long time. Hello to everybody. And these are two things that I love to talk about, ethics and the therapeutic relationship. And ethics is something a lot of people don't like to talk about. Well, we're going to try to change that a little bit today, because we know we usually talk about ethics when something goes wrong. And we're signing something for policies and procedures as somebody did something, so we're all signing that we won't do that again. But we're going to kind of stay away from that. And so let's just kind of jump right in. I like to start with a working agreement, and that's with any ethics discussion. A lot of times people disagree with what's said, and I think that that's important, and it's encouraged for people to disagree and have an opinion. But the only thing I ask is that rather than dig our heels in, and this includes me, on a certain position, that we are open to listening to everyone else's opinion and kind of see where that brings us. It's nice to get the larger picture and everybody's point of view. We all don't have the same point of view. I also like to ask that if you can leave your camera on, please do. It's really weird talking to a screen, so I'd like to peek over and see a bunch of faces. It makes it much more normal. If you're going to have patients coming in and out, I get it, you can't, but if you can at all, I'd appreciate it. So the important thing that we do when we talk about ethics is we often look at it as, how does it apply to me? But if we can change that, we take the fear out of it, and we look at, and the boring part out of it, say, how do ethics affect the field? It gives us a chance to learn without being personally attacked. A lot of times ethics discussions that may come up, we feel that someone's challenging us for something we've said or done, and I don't really want people to be in that position. I like to have conversations because they avoid problems later when we can talk about things. Like I said, it makes it a little more interesting. Ethics can be incredibly tedious, especially for those of us who have to do it every year for credentials, but I want to make it so it's a valuable and maybe a little bit interesting. So let's talk about the therapeutic relationship. In the beginning, the therapeutic relationship really was one-sided. Those of you who have been around a long time will remember some of this stuff. And the therapeutic relationship can really be explained by a simple picture and quote. And that is Lucy Van Pelt. If you're old enough to remember Peanuts, psychiatric help for 5 cents would be something any insurance agency would jump all over. But Lucy said, The world would be a better place if everyone just listened to me. And if you look at how things were many, many years ago, that's how they were. I was trained a long time ago to say, sit down, be quiet, let me tell you how to live your life, even though I know nothing about you, I know nothing about how you respond to things, and I've never walked in your shoes. Because we can. We'll talk about that a little later. So we would tell people, do this, do that, do this. And it started from the professionalization of 12 steps because that's all we had. Now that we have other options, we have to learn to listen to people and understand what works for them and let them determine kind of which route to go. So although I look at this and laugh, Lucy was right on at the time for the time that she was doing her psychiatric work. I'm not sure that it was okay to call her patients like Charlie Brown a blockhead, but Lucy's a special case. When we talk about the therapeutic relationship, the words here that are in italics are very, very important because it is a close relationship. And for it to be effective, we recognize it has to be consistent. We can't come out and change the game too much on the folks that we work with because there's some safety that relationship can form. We want to push the boundaries a little bit sometimes, but we have to be consistent. And hopefully that's for the positive. And it can be between two people, it can be in a group, but it's really in our position, talking about someone who's in treatment. It also matters in terms of a peer relationship. If somebody's doing peer work, there has to be a therapeutic relationship with boundaries and et cetera. Now, although they're different based on your role, the idea is still the same. It has a simple purpose. We want to help someone change their life for the better. The problem in the past was we were the ones who determined what better was. And that didn't always work out. As a matter of fact, when you look at all the numbers over the years in terms of outcome rates, they're horrible. And it's really because we expected to meet people where we were at, for people to meet us where we're at, not the other way around. Many of you know this is a review for a lot of people, but how important is the therapeutic relationship? It's incredibly important. We know most change, and research shows that most change comes from the area here of non-therapeutic, extra-therapeutic. And that's when things that happen outside of the treatment arrangement or treatment environment. People change because they decide to. Something has happened in their life that they want to make a change. Something that generally has nothing to do with us. Technique, whatever technique we use is about 15% of change. So the old adage that, all interventions work for some people some of the time is true. Last year, there was a study talking about the effectiveness of 12-step facilitation because there's all kinds of talk about evidence-based and things with 12 steps, although it was never designed for that. And what it found is it works for some people some of the time. It works better for some people some of the time. It works worse for some people some of the time. That's nothing we didn't know. So regardless of the technique, regardless of all the shingles on our wall, it only accounts for about 15% of change. The idea of expectancy and placebo effect works. If you think it works, it will. I can go back to when I worked at the old dispensary, and Jen Valda and I were talking with a client who came out and was saying that a medication he was taking was really working on his cravings. And I can't remember what it was. Oh my God, this I think it was Camprel. Camprel is great for my cravings for alcohol. It's absolutely fantastic. There's nothing in the pharmacology of Camprel that says it works on cravings. But did we tell him it didn't? No. Matter of fact, we told him, you should tell more people that. He believed it worked, and it worked. Baseball players, football players, they all have kind of little routines they go through before something happens, as superstition. We believe that we're going to do well if we follow our superstition. And we believe if we don't do it, it's going to happen. I got a Lucky coffee mug that I watch the Patriots with every week. It's about 30 years old, so I was drinking coffee out of it when they stunk. But to me, it doesn't change the game, but it enhances my enjoyment, right? Hey, it works for me. I've got this coffee mug. I love to watch it. It makes me enjoy the game even more. But when we talk about the therapeutic relationship, it has double the effect of anything else that we have our hands on in getting people to change. And this is research that we know. It goes back to, as referenced here, it goes back to Scott Miller's work. We recognize how important the therapeutic relationship is, but do we spend enough time talking about it? I don't know what the answer is to that. And I think it varies from place to place and person to person. But what we do know, it is the champ. The therapeutic relationship is the MVP of what we do. Nothing matters without that therapeutic relationship. I recently had a conversation with Sam Diaz from New York, who actually spoke at the dispensary talking about overdose prevention centers. And he talks about the relationship he has with the people that come in the door and the relationships the staff have. Now, they're not patients, but they come back because they get treated with dignity and respect and the safety and all the things that go with it. But those relationships matter, even in an environment that's not treatment, but it is therapeutic. And if we can save someone's lives, what's more important than that? The reality of it is, as our relationship goes with the folks we work with, so goes the treatment episode or recovery supports. Now, what does that mean in terms of the folks? You know, you don't have to show hands, but kind of who has a favorite client? You know, people will raise their hand. People who has a least favorite client, more hands go up because that's what people are honest about. You know, we do have favorites and least favorites because we're human. That does not have to affect the therapeutic relationship whatsoever. It does, and that's on us. And a part of that is practicing better emotional intelligence, which is a whole other subject. But we can control that, whether we like them or not. We can have a really good therapeutic relationship. You know, again, simple stuff. Why is it valuable? They have to have trust. I'm not foolish enough, and I've been around long enough to know that I don't expect clients to fully trust me. I wouldn't want them to. I worry about that person. I want them to always check out what I'm saying, but to have some basic trust in the fact that I'm going to be respectful of them, that I'm going to treat them as a person, that I do what I say I'm going to do, and I don't do what I say I'm not going to do. A great example of this is when a client will say to somebody, hey, I'm going to tell you that you're the only person I can tell this. I often will say, then it's probably something I don't want to know, because I can't guarantee that I'm not going to share that with the members of my team and with my supervisor if it's that significant of an issue. So I won't make a promise to say, oh, yeah, I'll keep your secret, because there are no secrets. There's confidentiality and need to know. But people don't like that, but they learn to respect it and understand what your boundaries are. And then there's congruence. We can't be happy and be thrilled and jumping for joy for somebody one day and saying great things, then giving them hell the next day. We have to be somewhat tempered in how we do it. They have to recognize, again, through us, that we have emotional intelligence, and then our responses are congruent with each other and congruent with what's going on in their life. We often get confused and will put things on the client. They're just not ready, and you name it. They haven't hit rock bottom yet. Actually, many people know, I've lost two family members, my brother and his daughter, to overdoses. My brother 30 years ago, his daughter about 4 years ago, and she was a former patient of the New London Clinic who just could not grasp it. And ended up dying in Groton in a motel of an overdose. And for people like that, we'll say they weren't ready, they hadn't hit bottom. Well, she hit bottom, he hit bottom, and it was 6 feet underground. That's the only bottom. So we want to raise that bottom. We want to motivate people to change. So it's our responsibility to really work on the therapeutic relationship. Most likely harder than the person that we're serving. I get the little hairs on the back of my neck stand up when somebody says, I won't work harder than my client on this. Oh yeah, you will. Or you should. And if I'm your clinical supervisor, you will, because you're a professional. This is not self-help. It's not going to the fellowship where a sponsor is saying, I won't work harder than you. That's our job. Our job is simply to motivate them to do better. And it's simple, but hard. So we have to work hard. The relationship falls on us. We have to develop it. And that lies solely on our shoulders. We have to do the heavy lifting on creating the environment and building that relationship. When it comes to maintaining the relationship, we still hold the heavier weight in that. Although the patient does take a lot of responsibility in that, but we have to find a way to reach them. Instead of saying, this is how we do things, this person just doesn't get it, which, going back to my Lucy slide, that's how it was 30-something years ago. Not that I've been around that long. Way, way, way too often, we put the onus of the therapeutic relationship on the shoulders of the client. Are they doing what we are asking? Are they following our advice? Are they listening? In many cases, are they following the same path that I did to really get the most out of recovery? When we look at folks that first come in the door, especially in OTPs, some of them are in the worst physical and mental condition they've ever been in their life. They've got the weight of the world already on their shoulders. And we want to put our work on them. Completely unfair. And we're seeing a lot less of this. But it was very, very common in the old days to say, oh, they're not getting it, we're just going to let them go. No, if something isn't working, we've got to find another way. Instead of saying, I just can't reach this person, they don't want to hear me, I've got to transfer them. No, that's our work. And anybody that's a clinical supervisor cringes at, I can't work with this person. You've got to transfer them to somebody else. Absolutely 100% the client has to join, using a social work term. They have to engage with us, and they have to participate. And that is their responsibility, but we have to motivate them to do so. That remains our responsibility. And participation doesn't have to look like agreeing with us. I love the client that comes in and says, I think you're a fool. I don't want none of this. This doesn't work. You're an idiot. I'm only here because of probation. Great. I've got something to work with. And that person is already telling me what's going to reach them. And I can say, so, it sounds like you don't want to be here. You're here for probation. What can we do to make it worth your while to be here? And they can complain, and we can let that, but we're motivating them to engage. We want to engage someone where they are at, and that will help them engage. When we say things like, they just aren't ready, I would ask, are they there? They're ready for something. May not be what we want them to be ready for, but they are definitely there for something, right? It's our job to find out what they are ready for and to motivate them as well. Anyone who thinks that there's no motivation in a client who has to survive in the world of being actively using, especially if they have other issues like psychiatric concerns, homelessness, etc., financial problems, they're motivated to do something. And that survival instinct is a great, great thing to tap into. Just because it's led to some negative behaviors, they're survival behaviors, and they can be turned around. The client can turn those around. So they have enough work to do. Do we want them to do ours as well? So what I like to say is it kind of changes. It's about you. It's not about me. It's about you argument, but not in the normal interpretation of the field. It really is about us in terms of creating that therapeutic relationship, creating the environment, creating the conditions for that therapeutic relationship. That is on us. I can't say that enough. And as long as we let the client go the route that they want to go. I'll share with you a cartoon later. I'll have to find it it's on my desktop here. I'll have to pull it up, but we'll do it at the end, just to kind of talk about that. So our first and most important ethical concept that we have is that we are the ultimate determinants of the effectiveness of the therapeutic relationship. We determine how it's going to go. I remember being in social work school and being a group major, and then in placements and at work, co-leading groups. And the relationship between the co-leaders really dictates how the group is going to go. We didn't recognize back then that the relationship between the individual leaders and the people in the group, the dual relationship of the group and the leaders, all of those things came into play. We didn't recognize that as much. And in today's world of things like manualized treatment, where we're following a script, we lose some of this. It's a great way to learn group process things and connecting with people. And in a group, it's really hard because you've got different personalities and things in there. That's why I love group. It's always a challenge. So this, I say, is non-negotiable. When we talk about the responsibility for the therapeutic relationship, it does, it's not negotiable that it lies on us, but not in the past, not what we did, not what we said, not what we thought, not the road we've taken, but in the here and now. We can be totally 100% authentic in the here and now without even talking about the past. Is it okay to say to a client if they're using terms of being offensive, to say, hey, I got to let you know, when you say that, I get offended. Can we work on that? Can we try to do it? But that's the here and now. That's true. That's really good use of countertransference. Or if they're using racist language, hey, I'd appreciate it. It makes me really uncomfortable. Can we use other words? At least in here. You're not saying you can't say that word out there, because people are going to do what they're going to do, but we're saying, hey, the here and now is making me uncomfortable, or I'm very glad you're doing this. Whatever it may be, being authentic in the here and now. We're not talking, well, when I was 25 years old and I'm 50. It doesn't matter. All that matters is what's the here and now. And because of the importance of that, that's where ethics come in. And that's where it gets really, really the nuts and bolts of what we do. So let's talk a little bit about ethics. Every credentialing body, every organization, professional organization has a code of ethics, and they're very different for different reasons. Organizations generally have policies and procedures which are not codes of ethics. And in many cases, policies and procedures are much more restrictive than what a code of ethics says, because the agency has to look about protecting itself and everybody. So you may be ethically allowed to do something, but based on policies and procedures, for whatever reason, not allowed to do that. Now, I don't ask anybody to go beyond that. You accept the position, you accept the responsibilities, and to follow those policies and procedures. But just kind of as informationally, like many organizations will have different policies about a client in a vehicle, in your vehicle. There's nothing unethical about putting a client in your vehicle if it's for a professional and recovery related purpose. However, organizations need to protect themselves and set boundaries. So that's just one of those things. But the 6 basic ethical principles, these are pretty universal for us. We believe in autonomy, that the client has a right to determine for themselves which route they want to go. If they wish to taper and no longer be involved in medication-assisted treatment, even though in our heart we see that that's could be a bad thing, they have the right to do that. What we see in the outside in other parts of the world, our clinicians tell people, you don't want to go and be on medications for this amount of time. You've got to come off. Well, they have a right to stay on. as long as it's medically appropriate and not doing any harm and helping them. We also have to look at the very simple thing of, avoid doing harm. Oftentimes, this is something that we have to take a look at, because what worked for us or what worked for another individual may do harm to somebody else. As uncomfortable as that can be, we oftentimes have to take a look at not our motivations, but what we say and what we do to make sure that we're not doing harm to this individual. Saying, well, we need to form a better relationship. Let's bring your mom, your sister, your brother, your wife in for a family session. That may actually do harm to somebody while being helpful to somebody else. So we have to pay attention to that individually. Everything we do has to relate to the ethical practice and principle of beneficence, that we're doing good, do good, and promoting the welfare of the client. Again, that can be a little uncomfortable for us depending on the client, but we have to pay attention to that. Justice is something in the field that gets misunderstood, and we can simplify it, and it's being fair and just, treating your least favorite client like your favorite client. There's no issue in having a least favorite, as long as we're aware of it and we don't let it dictate how we work with that individual. Fidelity. Fidelity means not necessarily sticking to a model, but making realistic commitments. Hey, I can't keep a secret. Excuse me one sec. Ethics make me choked up. So are we doing what we say we're going to do? And one of the big things for me that helps establish trust is the simplest thing we can do is be on time. If we tell a client group starts at 9 and we show up at 9, we're late, because we're saying it starts at 9, not that we're going to be there at 9. It's okay to say, hey, I'll be in there at 9 and we'll start shortly after. But when you say you're going to be there at 9 and you're going to start at 9 and you're just coming in, you're telling the client kind of subconsciously that you don't keep your word. Keeping promises. Hey, I will get that number for you. Hey, I will talk to the nurse. I will talk to the doctor to help explain what you said to me. I'll make that appointment for you, or I'll help you make that appointment. Those are really, really important things. And think about that. Clients notice that. I have a doctor that takes me in early all the time. I like to schedule the first appointment of the day when I see them, every 6 months, and they're usually early. He was on time last time I saw him, and I was worried. I had asked him if everything was okay. And he's like, I said, did you have a crisis this morning? He's like, no, why? Never mind. But it was just something, and I really appreciate that in him. He has a terrible bedside manner, but he's a good doctor and he's on time. Good enough for me. And then veracity. We have to be truthful and honest. No, I'm not going to call 911. Oh, it's okay to do that. No, I'm not going to do this, or I am going to do something and not do it. We have to be honest. And that's in the here and now, because they're experts at reading us. So many of the clients, especially those that receive services at an OTP, they've been through the mill so many times. They know better than we do what we're going to do, because they've seen it. So we have to be truthful in what we say we're going to do, and make sure that we have that follow-up. So, we'll take a look at some of these things, and then some of the issues that kind of come out around them. And autonomy is first for a reason, because that's the primary thing that we do, right? The client makes determination on what they want to achieve, and it's our job to help them get there. An example of this in psychiatry is when I first started working in this field in the early 90s, I was working in mental health, and we had a client who would not take medication every day for many reasons. He had a psychotic disorder and he did not want to take his medication every day. His option, what he brought to the doctor was, I'll take it every other day. And on the in-between days, because the half-life of the substance, I'll drink my urine. It was absolutely horrifying and disgusting. And the doc said, I don't recommend it, but if that's what you want to do, it won't harm you. And I asked him about that because I was waiting for him to say, you know, you can't do that. And he's like, look, it's gross, yes, but he wants to do it, and it's not going to kill him. And if nothing else, it'll keep him hydrated. And if it keeps him taking the meds every other day, that's all that matters. And I was horrified by that. And I had to learn, yeah, it's disgusting, but it's not harmful. I still can't fathom that, but and I still think about that, although it was 30 years ago. So autonomy is first. We meet them where they're at. So some of the ethical questions that come up with that are expecting the client to meet us where we're at instead of the opposite. Well, you need to do this and you need to do that, and you need to do 90 meetings in 90 days, and you need to do, whoa, hold on. That's not what treatment is about. That's part of an external fellowship that people choose to go with that. When they come to treat, we can't necessarily say, hey, this is where I'm at, meet me here. We have to accept that person for who they are and show them respect, even if we don't like their behaviors or agree with what they want to do. When we talk about coercion and guilt are really dangerous, because we know that many people have experienced trauma, and not all trauma was forceful. Coercion and guilt and things like that may be part of that person's trauma. So we have to be careful in what we say. And I don't think it's intentional. People don't want to coerce somebody. Maybe some, but in most cases, I would say no. When we fail to provide the benefits and risks of the options, or we fail to offer options based on what they want. When we talk about only the risks or only the benefits, that's really not fair. That's not informed consent. And do we confront a no when we want yes? Or do we accept it and have a conversation about it? So that's kind of some of the things that tie into autonomy. When we look at doing no harm, we know that we have to offer protection. And part of some of the ethical slippery slopes here are, do we speak on which is out of our scope and knowledge? Although I'm well informed in trauma-informed care, I was not trained in treating trauma. So I would have to stay away from that. We see it outside when folks are telling the clients that are in OTB, so you don't need to be on that. You're trading one drug for another, yada, yada, yada. We see that. That's outside the scope of their knowledge. When we oversell positives and don't identify potential risks, when we offer negative commentary about other professionals, yeah, DCF sucks. Yeah, probation sucks. Yeah, that person's horrible. Or falling victim to manipulation without evidence. Taking everything a client says about themselves as their truth, but it doesn't mean it's the truth, right? Not giving in just because a client pushes at it. It's okay to check things out and to tell them, hey, I'm not sure about this. I got to check it out. It's part of that being honesty. So these are some of the things that, for doing no harm, that can create issues. When we talk about doing well, we want to do what's best for the client. Not as easy as it seems. Again, we have coercion in this as a potential problem, just to see our point. An aggressive confrontational approach, and that's how we used to do things. Sit down, shut up. I'm going to tell you how to do your recovery, even though I'm not you. Being too passive, not following up for fear of an emotional response. A client may say something that elicits something in us that could be problematic, and not addressing it with the person and not asking about it because we're afraid they're going to get angry. And often, there's not managing the emotionality in the time of the session, getting somebody, up here on a scale of 1 to 10 out of 10, and then ending, right? Building and then saying, hey, we've got about 15 minutes left, and kind of setting the tone. And when the client becomes emotional, not responding with emotion, responding with rationality and calmness. It's a safety factor. When we talk about justice, we have to make sure that we're going to put forth the best effort with those that we don't like, those that disagree with us, those that have a difficult presentation. That's a nice way of saying those that have really active personality disorders, and people that others have labeled as non-compliant. What I remember about my time at the dispensary is there was a couple of folks would always say, oh, that person's non-compliant. And then they would go and work with somebody else and the whole route changed. And you'd hear, oh, you're kissing their rear end. No, you're just approaching them from a different perspective. You're not getting tied up in their personality issues. You're just moving forward. And then fidelity, delivering what we promise, being late to appointments. It seems like a small problem, but that's the first thing that they may notice. Not being prepared for a session. Think about us when we go to the doctor. If you have a doctor that's, when they first come in the room, they're scanning through your file. It's almost demeaning. Now, I know they don't know anything about me because they only see me for so long, but take a couple of minutes to look at it ahead of time, to understand what's going on, so you're not asking the same questions over and over again, and so someone doesn't feel that they're being listened to. Looking at our phone during a session. That it happens all the time. It happens when I train. It happens, and it makes me nuts. And it probably makes me nuts because I do it without knowing it. Whatever you see in others that you don't like is generally related with something that we do. So I notice that, and then cutting clients off to make a point. Whoa! Hold on, let me stop you. That's not really being fair. And again, it's just something that we have to look at. When we talk about speaking with truth and with honesty, are we overselling the benefit of something that we like? Oh, I know you said you don't like 12 steps, but maybe you'll meet some good people. There's a lot of good people there that are going to help you. Just try it. Instead of going with someone saying, look, I'll do anything, but I won't do that. Okay, well, what else? What are you willing to do? Instead of saying, well, we like this. And I use 12 steps as the most obvious, because for many people that work in this field that have their own recovery history, 12 steps are what got them where they're at. So it becomes universal prescribing. So are we overselling the risks of what they want to do? Well, I want to go to, I'm an atheist, so I want to go do smart recovery. Oh my God, you're never going to get anywhere without spirituality. I mean, without having a connection to something greater than yourself. That can create risk of relapse. Are we overselling that rather than pointing out the good and the bad? And something that's a common human trait, especially if you're on social media or watch either MSNBC or Fox News, depending on your view, identifying opinion as fact. It's just an opinion. And what's wrong with that? You can say, hey, my opinion is, as of saying, well, if you do this, then B. So when we talk about building the therapeutic relationship, the question is, who are these two young women? They're my nieces. Stick with me. There's a point. They know I use them. And it makes a simple point. The only reason I know the difference is by the way they have their hair, to be honest. And they're 31 years old. So we talk about what makes a good relationship, good therapeutic relationship. The client feels welcome. The client feels that you want them to be there. And that's something that comes across in our body language and things, not just in what we say. We have to recognize that relationships take time. And we'll talk about that. I've got that kind of asterisk for a reason. Good therapeutic relationship, the client is never judged. It's okay to judge a behavior in some cases, as long as you identify it as that. When you do this, I feel this way. Or saying, I see you, looking at a legal history, I see that you have a history of larceny. Instead of saying, so you're a thief. There's a difference between behavior and character assassination. We also have to learn to manage our own emotions. That's probably the hardest part of our job, because To say that we don't respond to issues of countertransference is absolutely ridiculous. There are many people who use it really, really well, but we have to manage our emotions. And our focus has to remain on what a client wants for treatment, not what we want. When you think of somebody who I'll use the Greater Hartford Harm Reduction as an example, when someone goes there for a needle exchange and that's all they want to do, that's okay. We're not harassing them with, you need to get the treatment, you need to get the treatment, you need to get the treatment. Maybe we're building that relationship by meeting them where they're at. And isn't saving them from a communicable disease enough? We put value on people's lives when they want recovery as we see it. Our words put less value on people when they don't do what we want. It's really hard sometimes to focus on what they want. We also ask open-ended questions. If we ask yes or no questions, we're often going to get yes or no answers. We have to do all we can for the client not to feel rejected. We cannot control that, but we just have to be aware of it. It's important that we plan ahead. And when I left the dispensary, we were short another person, and I had a caseload of 90. That's not unusual, or wasn't unusual in those days. It's hard to plan ahead, but you have to, because it shows value in that client. And we have to continually focus on the needs as they define them. We may want to help them expand their view of what those needs are, but if they shut it down, they shut it down. We don't keep going. And the whole thing of referring out, oh, I can't work with this person, that's on us, man. We've got to figure that out. So that becomes a last resort only. Notice what's not on that list. Our own recovery status is not on that list of what makes a good therapeutic relationship. Why do we think it's so important clinically? We're not in peer roles, we're in clinical roles, and we often think that that is so important. Now that I probably annoyed a few people in the room, let's talk about it for a second, because I really think that that is important. Clinician self-disclosure at best is a slippery slope. I hope that anybody who uses self-disclosure has a supervisor skilled enough to help manage that and to manage the members of the team that choose not to self-disclose and all of the things that can come with that. So let's look at some of the ethical questions that exist, some of the things that make that slippery slope. Now, they're not true in all cases, but they're possible. We will often say, I only self-disclose when I think it's good for the client. But when do clinicians who generally self-disclose do that? Immediately when they sit down, hi, welcome, my name is Jeff, I'm in recovery too, I'm just like you. I know what it's like. How can we know what's best for them when we've never met them? We'll think, I want my client to know that I'm just like them, been where they're at. Number one, we are not just like them. And number two, we have not been where they are. Even if we've been in the same environment, we are different people with different responses. And we've got a whole host of stuff in our psyche that makes our response to situations unique. And so does everybody else. So let's get back to my nieces. Jessica on the left and Jackie on the right. My sister did that cute thing of giving them names that are similar, and then she used to dress them alike when they were kids, whatever. They're monozygotic twins. I like to say that because it makes me sound smart. They are from the same egg. My sister and her husband have been married for 40 plus years. So the environment has been consistent for them. And even if they get divorced, there's consistency depending on the time. They grew up doing everything together. They both went to college and played basketball. At this point, they live a quarter of a mile from each other. One is building a house a mile away. I don't know how they're going to take it being so far apart from each other. However, Jessica is like my brother-in-law. She's very easygoing until something happens that she's had enough. And then here comes the volcano. So she's fun to be around most of the time. Jackie is very driven, very planful. She has to deal with emotions in the moment. Oftentimes, she's not fun to be around, especially if you make her angry, because you ain't getting out of there till resolving it. Jessica could not wait to get married. It was one of the things that was on her list. Jackie, her sister, put her marriage off as long as she could. She did everything to delay it. COVID made her happy because she could put it off for another year. Jessica is married to a woman, and Jackie is married to a man. Jess is very content to let her wife run the show. Her wife handles everything. She's tremendously organized. She's a nurse, so she's got everything where it needs to be. She's great at that. Jackie is the boss. Her husband, if he has any sense, and he does, will just say, I'm going to let you run the show. You got this. I'm going to go with it. Jess is a high school teacher and a coach. She loves that interaction with the adolescents and loves interactions with people. Jackie has an MBA in business analytics. She has a relationship with numbers. So even though they have the same DNA, nature and nurture are as identical as possible between two people. They're very different from each other, and they have unique responses to situations, just like all of us. And they even have that weird twin thing that I never thought existed until I saw it. Hey, something's going on with her. And they know that, but they're very different. So how can having a similar experience make us just like someone else? It's not the same experience because there are so many factors that are different. So it's okay for it to be similar, but it's not just like us, just like someone else. And why would it be? We may be able to walk in someone's shoes, but they're still our legs, and it's still our walk. So let them have their legs and their walk and learn from it. Oh, yeah, I know what you mean. Do we really know what they mean? I understand. You know, those are some dangerous phrases to throw out there because we may not. Why not learn more when we can? Learn about that, build the relationship. I also want to talk about one of my colleagues, Dr. Bob Lynn at the Rutgers School of Addiction Studies. He calls something, it warns us to not fall for the fallacy of attribution. It's human nature. It's not just part of our, as clinicians, part of our stuff, but it means that people come to us in pain, in physical pain, spiritual, emotional. How is talking about our history going to help that relationship? Do they really care? The fallacy of attribution is how I interpret things, how I experience things is how everybody else does. For 40-something years, I've been a Patriots fan. The first something years were miserable because I wanted them to win. Then the last 20 have been great. Somebody who likes the Jets has the same, you know, they're happy when the Patriots lose, sad when they win. The same event, two people, and one of my closest friends, we have different experiences of it. We both love football and love to watch it, but I cheer when their team loses, she cheers when mine loses. And so the same event, we have different responses to it. So the fallacy of attribution is, as I go, the world goes. Or as Lucy would think, she's the center of the world. And I think about it this way. Somebody comes in, and we've seen folks, right, that have come in, for an intake, they haven't used since yesterday. They're in withdrawal. They're sweating. They're holding in diarrhea. There's aches and pains. Their head is throbbing. All they want is help. And you come in and say, hey, I'm Jeff. I'm just like you. I did this and I did that. Do you think they care? If I go to Dunkin' Donuts in the morning, I avoid making eye contact with people because I'm afraid if I say, how you doing, they're going to tell me. And I'd like to think that I'm fairly healthy emotionally. I don't want to hear, when I say, how you doing, I just want someone to say, good, you, and then move on. So they're sick, they're miserable, and they want to hear a story about us. Why don't we just open a book and read them a fairy tale? Or just read empty words on a page? It's the same thing to many folks. They don't care. They may care later, and how we handle that is important, but they probably don't. They just want help. Some final notes on this, I don't want to harp on it, is clients will ask. We know that. Is it because it's just a conditioned response or expectation for them to ask, are you in recovery? That's kind of what they do and that they're taught to do. Or do they really care? Is it a defensive maneuver? Are they just trying to say, tell me, I don't want to talk about myself right now. So I'm going to ask you about you. And I've been around long enough to know that you're going to spend 12 hours telling me about you. And I'm off the hook. Are they avoiding that focus on themselves? And the reality is often we don't know how to answer that question therapeutically. I remember learning only one way to answer that. And many people that have been around know that it's not about me, it's about you. And if a physician or someone, a caregiver ever said that to me, I would think, what a jerk. That's a rude response because my question didn't even, I didn't get the dignity of a decent response to it. Clients may feel the same way. Or we often do something else that's almost as bad and really entertains me is, we're all in recovery from something. Oh, no, we are not, even if we are. It's about what their needs are, not about creating something that's not there. It often creates a hierarchy among staff with the clients, those who disclose versus, oh, I want to go to so-and-so because I know they're in recovery. That makes them better. Simply because they're in recovery themselves, they're better. 5 years ago, I was in the hospital with pancreatitis. I was in a coma for 17 days. You know what I know about treating people in a coma? Nothing. You know what I know about being in a coma? Nothing. I was in a coma. I can't remember a darn thing about it. So I would be completely unhelpful. I'm not saying it's unethical. I'm just saying that disclosing recovery status can really be a problem, and supervision around this issue is an absolute must. It can be an effective way to foster a therapeutic relationship to show that you're attuned. But again, it goes with the here and now. Self-disclosure isn't be, I'm in recovery in this. Self-disclosure may be, I'm really happy that you said that. I like what you're saying. I'm uncomfortable that you said that. From what you're saying, I would be angry if someone said that to me as well. That's self-disclosure in the here and now that's valuable. Self-disclosure of recovery status does not build a therapeutic relationship. It can often destroy it simply because we're saying, because we have something in common, I'm just like you, and we're not doing the work to build ourselves and not asking the client to do the work too. We know that clients have to live in a world where people are not like them. Right? We have to, as they say in the rooms, right? You have to meet the world on the world's terms. If we do everything to avoid them having to interact with folks that are a little bit different than them, what good are we doing? We're teaching them how to live inside that recovery world bubble, but are we teaching them to live outside of that as well? Let's talk about informed consent. I said we struggle with that, but so many people miss the mark completely on what it really means and what it really is. It's not a moment in time. It's something it starts and continues throughout the treatment. Informed consent. So when somebody signs a consent for treatment when they come in the door, courts have ruled that those are invalid based on medical science and the testimony of doctors. I never signed up for this. Yes, you did. You signed this form, but I was in the middle of detoxing. My brain wasn't functioning right. They're absolutely right. They can be invalid as well as releases. So we're always talking about that stuff, right? If somebody says, oh, if you don't sign this release for DCF, you can't be here. Well, why? That's their issue. But we can say, say, hey, can you call DCF and tell them and send them my urines because they've all been negative? I can't. I'm sorry. You haven't signed a release. Well, I'll sign a release for urines only. Okay, we can do that. And then when you send them, I want to retract it. We can do that too. So are we using it as an ongoing process? Hey, if you do this, just so you know, here's the good and bad. It may protect us legally, maybe, but it does not ethically. Are we always checking in with our clients to see that things are going well? I sent Darcy the slides so that if anybody wants them, she can send them out. This comes from National Institute of Health, and what they say informed consent is, but do they have all the information to choose to undergo a procedure or intervention before it happens? That's why I love that show, Intervention. Just think about that. Not only is it ridiculous the way they do that, it's also illegal. You've got somebody with no clinical background diagnosing and determining level of care, and then telling the family they have to shut somebody out if they don't follow this, instead of saying, well, what are you willing to do, right? There's no consent involved there. We ask someone, if someone says, well, I'll go to yoga. On that show, they'll say, nope, you've got to go to New Mexico and you can't talk to your family and your kids are never going to talk to you, which they end up doing anyways, and ruins the whole idea. Instead of saying, well, what are you willing to say yes to? So when we talk about what it entails, when we talk and looking at documentation, if we're going to do, what's the nature of the intervention? What are the risks and benefits? If we don't talk to somebody and address one of the things is, oh, the methadone detox is 10 times as bad as heroin detox. Well, first, it's not a detox, it's a tapering, and we can look at that, right? Are you given the accurate information? What are reasonable alternatives? What are the risks and benefits of alternatives? And are we assessing that patient's understanding of what we're saying? Are they asking repeat back? Are we asking them to give us an idea of what we just said? That's all great treatment stuff. People think that it's not, but it's giving somebody control of their own life. We have to remember that the therapeutic relationship for the client, and sometimes for us, depending on our countertransference, it's a recapitulation of other relationships in their life. When they respond and they experience transference because we arouse something in them that reminds them of another, we see how they are in that relationship. We see how they relate to others. And isn't part of what we do to help them relate better to others, or to tolerate others that are different from them, or to live in a world that's really often unkind and unfair? We have to see how they work in other relationships. So when they ask, I don't understand this, and we can say, well, when I brought this up, here's one of the things that you said. So let's talk about where that came from, right? Not necessarily in the moment, because there's still emotionality, but kind of understanding that they only know, relationships in the way that have worked for them. And in many cases, it's survival. And survival involves manipulation and all of the thing, and lying and all the things that go with it. So why would we get mad about it when we know that's how they survived, instead of just kind of talking about it, being open about it? The more comfortable the client becomes with us, and the more they develop a trust, again, we know trust is limited, but we'll take what we can get. We might be lucky enough to see a lot of their usual behavior patterns. They're with us enough and they find us safe. We may see how they interact with their parents, with other people, with family members. We know that the relationships often break up when somebody finds recovery. Even if the other person is not actively using, it changes the dynamic, because relationship skills may change. Are we helping somebody understand that? Let's look at some of the other ethical issues that can arise. We got to remember, relationships are biopsychosocial and spiritual in nature. That makes them complex, right? But we recognize for sustained recovery, relationships are necessary, some sort of relationship. And that can be our view of spirituality or the client's view of spirituality, if that's what it is, not necessarily saying you've got to go to church, you've got to have God, you got to have this, but we do need others. For our clients, many of their relationships have been sociopathic in nature, getting their needs met without concern for the needs of others. It's generally unintentional. I don't know too many people who are really comfortable with saying, yeah, I stole my little brother's Xbox to get 20 bucks so I could get a few bags. It's sociopathic, but it doesn't make them sociopaths. Very different. So those are things that create problems. Relationships are really, really complicated. And we have to watch out for the conditioned response. That's a red flag for us to kind of change what we're doing. If the client fully knows what we're going to say, they're dictating the therapeutic relationship, possibly for their own safety, but in an unhealthy way. If they yell at us and we yell back, we're just fitting into everything they already know. If they know how to survive that. Was anybody here grow up in a family where their mom or dad was a yeller? Oh, yeah. My mom would yell and scream, and I didn't hear a word of it. When I walked in the house and I heard, we need to talk, Jeffrey, I gave up whatever I was doing because I was afraid she already knew. It scared the daylights out of me. Or vice versa. You know, if someone had a parent that never yelled, and when they raised their voice, everyone hid. Think about our clients with that. If they say something that people would normally get angry about, especially early on, you're an idiot. I'm not an idiot. You're going to do this? You're going to call me an idiot? I'll show you. That's what they expect, and that's what they can handle. There's no work in them in working on relationships that way. But when you say something like, I'm sorry that you feel that way, but we did agree you're going to do this. You know, hey, that may be true. I may be an idiot, but we're here, and what are we going to make happen today? They look at you like a cat when you put something behind, you hold something in front, and then you put it behind your back, and the cat looks at you like, hey, where did that go? It makes the client do the work on relationships rather than just going with what they know. Survival works on the street. It can create problems in the world that their world of recovery. Those survival skills. We have to learn to kind of help them know when to shut them off and think. And what's better than getting a client to think? One of my favorite things, we'll talk about relationships. If you've never seen The Wire, watch it. It's absolutely fantastic. But this here is my man, Bubbles. Bubbles was on the street selling stuff out of a cart, doing whatever he needed to do to get high. He had relationships, though, even while actively using. He had a relationship with Kima. Kima here is a police officer, a narcotics detective that would use him as a confidential informant and give him drugs. So he would give information and he'd continue to get high. It was a great relationship for him as long as no one knew he was snitching. He also had a relationship with this kid, John. John was his best friend, if not anything else. They were very close. And he kind of showed him the way of the street. This is how you survive. And when John died, he was crushed. This here is his sister. I can't remember her name. He had a terrible relationship with his sister because he had abused. Anytime she wanted to be kind and tried to be kind, he went back to those behaviors that were most comfortable for him, and it fractured that relationship. He worked on that relationship as he worked on his recovery. So she let him live in the basement, but he could only be there when she was there. He couldn't come upstairs, couldn't interact with anybody else. To ultimately, as he did better and better, he had dinner upstairs, and then he cooked dinner upstairs. So he developed a relationship. And then he had a relationship with this guy who had nothing in common with him. A guy named Wallen, who ended up being his sponsor through NA. Wallen was not only older, but he was white, and he was kind of rednecky. And Wallen was played by a guy named Steve Earle, who's a musician, who said when they cast him in that, oh, wait, I get to play an old white junkie whose life is falling apart? That's not a stretch for me, because he had been there. So he drew on his own experience. And he kept telling this guy to go pound sand, and this guy stuck with him and just talked to him about whatever he wanted to talk about, and was a confidant, and always said, there is another way. So he truly kind of obeyed the tradition of attraction rather than promotion. He said there's another way. All of these relationships, he had to learn how to change. Kima used him to get what she wanted. He was angry about that, but he worked that out with her. So as these relationships go, even when he was actively using, these relationships served a purpose. They served a different purpose in his recovery. So the scope of the importance of the therapeutic relationship really dictates that we have to talk about it quite a bit. And we must consider it to be really, really, really important. And then when we talk about ethics, ethics relates solely to the impact on that person served, not on our intentions. As somebody who does primary investigations for ethics, I have never asked, although I wanted to, what are you thinking? Because when somebody makes an error, and I'll give you a very common ethical error, is sharing information without a release. Calling an emergency contact when it's not an emergency in the eyes of the client, right? So it creates some issues with their relationship. Oh, well, why'd you call my sister? Well, you didn't come, and I was worried about you. My sister doesn't really know I'm here. That's not an emergency for me. Our intentions were good, but it's still an ethical violation. We could always have a conversation at the beginning, say, before you sign this, please tell me what constitutes an emergency so that I know that I don't violate your trust. Unconscious is one thing, right? But not coming for a couple of days, no, that's not an emergency. If you don't see me for 4 days, yes. So letting them tell us what's an emergency takes the ethical danger away from that. It gives us more knowledge, right? Because our intentions don't matter, only the effect and impact of the client. Most ethics issues are done with really, really good intentions. Well, I know that this is a good meeting, so I took them to a meeting with me. Hold on. Way too far for this role. You can't serve both roles as a sponsor and as a clinician for the same person. So I appreciate, the time today. I'll be glad to answer any questions. I have to do my little sales pitch. Please, please, please listen to our podcast. It's free. I have a lot of interesting guests. I have controversial guests. It's a lot of fun for me to get to talk to these people, and we have some really good conversations on things that aren't generally talked about. I have one up right now that we're talking with. Spoke with an individual at a genetics company who does genetic testing to find out which medical interventions work best on mental illness and for somebody with a substance use disorder, what they may respond to best, so you're not playing around with medications. And it's really fascinating. And I have one next week talking about what really happens at the Overdose Prevention Center with Sam Diaz, who, if you didn't hear or see him at Root in Manchester, he was absolutely fantastic. So any questions? Of course you're nodding your head no, Sarah. Well, if you can find me through the website, my email. I appreciate your time. I saw something just popped up in chat. Thanks, Amanda. I appreciate the kind words. That's very nice. And listen, everybody, stay cool, stay in the AC, let your clients hang out a little bit because it's hot out there. Have a great day. I appreciate everybody. Thank you very much.